All right, thank you.
On camera.
I got up this morning and, we've done 4 of these.
Yes.
And I feel a little bit like the guy in Groundhog Day. I'm still in New Jersey and, you wake up and, but it's a wonderful place. And I thank all of the folks from New Jersey and that make this possible. So, we're going to talk, we're going to talk about the mobile response system in Milwaukee County. Talk a little bit today. Today is more like organizationally structure and history and how it evolved. Tomorrow will be a little bit more on the clinical best practices side. So we'll begin with a little bit of the history. Mobile response services in Milwaukee and the development of what we call the mobile urgent treatment team goes back 22 years. Now, I'm going to be doing, if I keep coming to New Jersey, someone's going to shout, I wasn't even born then. We actually, 22 years ago, in Milwaukee County and the state, we applied for the first, we were the second round of federal grants. There were 10 grants awarded in 1994, and that followed, I can't even remember who had the first 4 grants, but the year before that. So it does date back quite a long way. So, and you are able to sustain, and these things do go on. So, but it was 22 years ago that we developed this, and today Wraparound Milwaukee is a single coordinated system of care that serves Milwaukee County youth. There's 1.1 million population in Milwaukee County with serious emotional, mental needs and their families across child service systems. Now, as we talk about this, 22 years ago, when we started Wraparound Milwaukee, I was hospital administrator running the Child Adolescent Treatment Center in Milwaukee, which was operated by Milwaukee County. We were one of the largest freestanding psychiatric hospitals in the United States. When I came, we had 120 inpatient psychiatric beds. And even in when we applied for that grant and got the grant in 1994, we still had 90 inpatient psychiatric beds. Now, I was probably either a really bad choice or a really good choice to start this, because I didn't believe in hospitals. And I was a hospital administrator, and I really was orientated towards community-based systems of care, just looking for the opportunity to continue to move in that direction. I was also a former child welfare administrator and a juvenile court administrator. And so the orientation I had, and fortunately some other people had early, was that if we build systems of care, these systems of care should be built across child serving systems. And in fact, when we built it, and we had a dinner last night with Claudia and Justine, we're talking about what some of the lessons learned in Milwaukee about building and sustaining a system of care. We built the system of care for child welfare and juvenile justice. We didn't build the system of care for mental health, because when mental health builds things, it looks a lot different than when child welfare and you're building a system for child welfare and juvenile justice kids and families. So there was that orientation very early on as we began building that system of care. But the important thing with mobile response very early on, 22 years ago, is that it was actually the first component of the system of care we needed to build, because if we were going to move towards a community-based system of care and we were going to further reduce hospitalization, we needed to have an ability to reduce kids coming in. We needed to reduce inpatient psychiatric use for children and adolescents, and we needed to really keep kids out of emergency rooms. We really needed to see them more often, basically in the community. And as I said, we had 90 beds. Within 5 years, we closed. The Child Adolescent Treatment Center was closed. So we moved very quickly, really, at developing our system of care in Milwaukee. Now, today, Wraparound Milwaukee, as it's called, is operated under the auspices of the Milwaukee County Mental Health Board as a unique care management entity with a capitated contract under the Wisconsin Medicaid program to plan for, provide, pay for, and manage care for youth with serious emotional mental health needs and their families.
So there's been some change over time as we went from the county operating it to a private mental health board operating it. But it's still really more so a publicly operated system of care. In 2016, we served 1,670 families, and the average daily enrollment is 1,200, and currently 1,213 families are enrolled in Wraparound Milwaukee. Probably on any half of those are child welfare and juvenile justice youth, so they are involved in those systems. So there are key service components, though, and I think you'll hear that I know you'll hear that from New Jersey and Connecticut, is that we all feel very strongly that mobile crisis response systems, MRSS systems, really should be built as part of a system of care. They're really not standalones. They don't work as well. For the simple reason is if you build a mobile response system, and after you do the mobile response and the child and family still need care and they need a lot of comprehensive, you have to have someplace to go. You don't do them a service if all you're doing is responding to the crisis. On the other hand, if you have a system of care and you have care coordination and you have wraparound, but you have children and families who are in crisis, and even with good crisis safety planning, it's not always enough. Sometimes you really do need that mobile response system, and you need a very comprehensive system to respond. So these things tend to really work, I think, best, and you'll hear that from Connecticut and New Jersey too, if they are embedded in and it's all part of a system of care. Four key service components of that are going to be care coordination, and we have a very strong high fidelity wraparound approach in Milwaukee. There's over 120 care coordinators in the Milwaukee system that are serving very low ratios, 1:8 to 1:10, depending on the court order type, if we have that. Mobile urgent treatment team, obviously, which is our 24/7 crisis response, and planning is another critical part. A comprehensive service array, which is the availability of clinical and support services to meet needs that are identified by your child and family teams. We have a very comprehensive array. We have 70 different services in the wraparound service plan and our benefit plan delivered by 160 agencies in the community. So it's a very robust, and it was built that way to be very robust. And it was built to be inclusive of as many agencies as possible because we didn't want to exclude. And then family support and advocacy services, which are our family support and advocacy Families United of Milwaukee, so all families have access then to a family support advocate. Now, there are other important components, don't get me wrong, quality assurance, information technology, medical oversight, public relations, finance. There are a lot of other critical parts to a good system of care, but these are really key ones for your service on the service side that you need to have in place. Now, as I said, MUTT, or what we call the Mobile Urgent Treatment Team, they got the affectionate name of MUTT, and over time, there are many discussions about the MUTT name. Some people, well, that's not a good name, but every time we wanted to change it, people would go back to, you mean the MUTT team? So, okay, we're kind of stuck with it now. We did it, and family's best friend. So, I mean, it's like, but we began, Mobile Urgent Treatment began in 1995, and Chris corrected me. It was 1994, which was that we actually, in the fall of 1994, I had us doing it at the beginning of 95, but he went back to the archives. He's pretty old himself over there, and and found that we did begin in the towards the end, the latter part of 94, but began during year 2 of our grant that initiated Wraparound Milwaukee as a service to children enrolled to keep youth and family together, support care coordinators in crisis, safety planning, and particularly reduce ER use and prevent the need for unnecessary inpatient psychiatric care. Because we had a goal in mind in our system of care, and our goal in mind was we felt the role of Milwaukee County Behavioral Health and of the community, you could call it the community mental health system, should not be inpatient care. We should get out of that business. It should be running a system of care. We don't need to do outpatient care. We don't need to do day treatment. We don't need to run a hospital. And in fact, if we run a hospital, build it and they shall come, we're just going to hospitalize kids. So we have to move towards closure of that and not be in that role. It makes more sense for us to develop the system of care across child-serving system. So that was the goal, but we really needed then to get at inpatient, and it was very much early on, and I'll talk a little bit about financing, a strategy we had with Medicaid, which was to reduce, they wanted to reduce inpatient psychiatric care, and I was able to negotiate a deal and saying, okay, we want to go towards a capitated contract with you eventually. We'll do for the next 18 months, we'll do a strategy of reducing inpatient psychiatric use at our hospital and other hospitals, and you in turn will pay us the 40% state share of the DRG rate that would be paid for that diagnosis for that child if we can keep that child out of the hospital for 30 days. You can invent strategies sometimes with Medicaid, and that worked very well for them, and we just went really quickly because we developed the mobile team with Chris and others and began seeing that a lot of children and adolescents did not need to come into the hospital, particularly as we saw them the more we could see them in the community, in their home, in their school, the better off we are. And I have in terms of a lesson learned, we very much, we're building this as a child-adolescent mobile team. I think for us it was more effective not to ever bring these together with our adult team because of philosophical organizational differences. And we'll talk a little bit more about that. But then, so we're building the mobile team as part of Wraparound Milwaukee. Then the state, in 1996, a change in state law, a new state law, HFS 34, required all Wisconsin counties to plan for and provide mental health crisis services for adults and children. So that change created new fee-for-service funding under the Wisconsin Medicaid program then for the provision of mobile crisis response and optional stabilization services. So the state made MRS a much more comprehensive service and required all counties. So we were already built a team for Milwaukee County related to directly as a gatekeeper for Wraparound Milwaukee. So it made sense for Milwaukee County then to designate the Mobile Urgent Treatment Team as Milwaukee County's mobile response team. And under state law, under HFS 34, all children and adults have to be seen. It's not, whether they have funding or no funding, everyone has to be required. And if under Wisconsin, even if you're in managed care system, if you're in a managed care, we're a managed care state, they made crisis services separate. They wanted the counties to be responsible to provide the crisis services because they didn't want anyone to be denied that care based on the fact that they were in a managed care plan and that could make a difference. So I put the counties and made the counties responsible to have a designated system. So we now have Mobile Urgent evolved to be the designated crisis service system for all children in Milwaukee County, but it also retained its gatekeeper functions, you could say, for Wraparound Milwaukee. So we were doing both in the building of the system. Then historically, in 2002, crisis stabilization services, including crisis group home and what we call our crisis one-to-one stabilizers, were added basically to our service array. They were created in HFS 34, but HFS 34 is a little bit vague about some of the crisis stabilization, so we kind of invented some of the stabilizations, particularly, and Chris will talk about the one-to-one stabilizers, which have really been a key to our system. Then in 2005, we opened a contract with child welfare for creation of a dedicated foster care crisis team. They wanted their own, embedded within us, they wanted their own crisis response available to children in foster care because they were under a federal lawsuit related to the number of failed foster placements and the number of kids moving. There's a percentage, and too many kids were failing, and moving into too many different placements. So the way they thought a lot of kids moved were child fails a test, gets into a fight at school, gets suspended, goes back to the foster, they get into an argument, foster parents call child welfare, remove this child. So what we wanted to do was give the parents and the families someone to call to respond to crises so that youth were not getting removed. So a lot of this had to do with this federal lawsuit. And so child welfare contracted, and child welfare, and we expanded that. Now it's a $750,000 contract with child welfare. So we have multiple funding sources. So we have Medicaid paying, we have child welfare now paying to do that, and adding to our blended funding pool. In 2006, we got a contract with Milwaukee Public Schools for a specialized crisis team for grades 6 to 12 to respond to school aggression, suspensions. They wanted their own team too. In 2010, though, the state funds that they were receiving for that ended, and our governor pulled a lot of the funding, pulled $1 billion worth of funding away from the schools throughout the state. So that kind of ended that. And the final piece of the evolution of the mobile team was in 2015, where the mobile urgent treatment team, under a grant through the city of Milwaukee, we began really the Yale model. I don't want to give us, which is kind of a community policing model. And this is the idea of developing a trauma team attached to it, and they're stationed with a police precinct. And the idea there is, this isn't a family who calls because their child was disruptive at home or has a mental health crisis in their home. This is when the police respond to domestic violence, a crime, which to them is a crime, but there are children that are in that home that are then exposed to the trauma of that event. So the idea is for the police to begin to recognize trauma and to have a referral source. So the mobile team gets embedded then into a local police precinct, and we've started that, and hopefully that will get expanded. But that whole idea of expanding the role. So you can expand the role of your crisis services. They can be doing a lot of different things, and we continue to look for, we're doing some of this now with first episode psychosis. So we have 2 teams right now, and Mobile Urgent is doing a lot of work in that particular area. So we keep expanding. You can't narrowly view mobile crisis services. You think about the expansiveness, like the community policing and all the opportunities, and all, when you really think about all the trauma that those kids and families are exposed to, that never, later on, those are the kids that enter the juvenile justice system and the child welfare system. So if you can intervene earlier, you can oftentimes prevent that. So it's that Yale model. So these are all the evolution of the mobile team. And as I think about the 4 things that really in Milwaukee and the need for mobile response services was, 1, to create a single point of access for children and families experiencing a mental health crisis that they can call, and that team is available to basically intervene wherever that crisis occurs. Schools, homes, they can go to the emergency room, they can go anywhere, basically the police station, they can go to detention if it's there, wherever the crisis is occurring, but have that single point of access for children and families experiencing a crisis. 2 was the need to reduce the overutilization of emergency room and psychiatric inpatient care. And we reduced the use of psychiatric inpatient care for kids in wraparound in 1 year from 5,000 days to 500 days. We made that just an incredible reduction by just having access to the mobile crisis team. And when you reduce when you can reduce that much, you don't need a 90-bed hospital, when your length of stay goes from 70 days to 2 days. So that was one of the reasons we could eventually do that. Clinical triage and assessment for entry into Wraparound Milwaukee. Our mobile team plays an important role because in our contract with Medicaid, if they go out and see a child and they assess and the child needs ongoing services in Wraparound Milwaukee, they have under our contract, they can make that assessment. So, you pass go, and their assessment, they can automatically make that assessment, and they're automatically enrolled, basically right from the mobile response team. So we needed that clinical triage and assessment capabilities for entry into Wraparound Milwaukee. So here, the connection again to your system of care. And finally, to reduce secondary placements from the hospitals into residential treatment centers. So mobile plays a role. It's not that they're going, and occasionally they do go into a residential treatment center. We have certain provisions that we can do that if it's child being putting a crisis plan if they're going back into the community. They can do that. So for the transitional purposes, that can be done. But there's a secondary effect we found, which is kids went from hospitals to residential treatment centers. They fail in residential treatment centers, they have a crisis, they go back to the hospital, and we wanted to avoid that. So mobile urgent plays an important role in doing all of that. And Chris can be as busy talking to residential treatment centers about their crisis safety plans as he is working directly with hospitals. So that kind of gets to start. Now for the components of mobile urgent, I'm going to turn it over to Chris.
I'm really excited to hear your stories, and I really appreciate that, especially this morning when you're talking about where you are and where you come from. I got a BS from Lemoyne College in Syracuse, New York. I proceeded to get an MS and a PhD from UWM. And I started to work at the MHC, which became the MHD, and now it's the BHD. It was originally the mental health complex with about 2,000 inpatients. Who names a place with 2,000 inpatients the mental health complex? We did that in Milwaukee. Well, then I started out with Bruce at CATC, that's now CAIS. I just relished my time on the MUTT team. I was on the DMHTF for a while, and I know a little bit about evidence-based therapies, CBT, TIC, CBT. I really don't know a lot about EMDR. Big deal, right? As my mom told me when I got this degree, she said, remember, son, it just means piled higher and deeper. And then she added, of course, don't ask me what MS means. She was so down to earth. And we need these because we need to talk shorthand to each other, right? It helps. We talk about our 1915 I's and everybody knows what that is and all that stuff. If we didn't have all these acronyms, where would we be? We'd be SOL, right? But I started out at CATC, which was the inpatient service, and Bruce and I worked with a lot of other folks very diligently, very persistently, and it wasn't easy. Winston Churchill said that success is just moving from failure to failure without losing your enthusiasm. That's what it was like for me. And I'll move away from this and I'll stop driving Caitlin crazy, but we'll talk more about this tomorrow when we talk about the rubber hitting the road, the concept of the organizational chart versus what it really looks like on the street. The word I want you to think about is that you need to do if you're really going to do this work is grit. That's what you need. I'm the guy that's the on the ground guy. And that's what you need. More about that tomorrow. But for today, I'll talk to you just briefly about the components and some other aspects of it. And I encourage you, hope I can use the little, the pointer. Is there a red?
No, just the
Oh, shoot, okay. So look at this. If you click on this, somewhere in our
In the library.
material. Yeah, look at HFS 34. That'll give you a lot of information about what the state of Wisconsin eventually arrived at as parameters, guidelines. Bruce is right to say they had some more or less amorphous, vague suggestions, guidelines in the code, which work to our advantage. More on that when I talk about stabilization services, but this is key. For those of you wondering, what does it take to put a crisis team together from an organizational, from an operationalized standpoint, that is very informative. Tomorrow, I'll talk about technology. That's not up here. And I'll encourage you, maybe I'll even ask you now, how many of you have, let's say, a web page that families can go to and access service contact, that kind of stuff? Okay. How many of you are using or encouraging the use of texting with kids? Some people, okay. We'll talk more about that tomorrow because kids are different than us. And they communicate differently. And in Ohio, I think it's Ohio, they're doing some research on texting, and they're highlighting the idea that many youth find it so much easier to text information to each other about themselves than they do actually delivering the words. Your body has your skin has a galvanic skin response, your heart rate goes up. When you say certain words, when you talk and you hear your own voice, texting's a lot easier, okay? That's not up here, but I'm gonna encourage tomorrow everyone to consider that. Walk-in service, we have a little bit of that. We used to have more of that. When we were stationed up at the old hospital grounds, we had more walk-in traffic. I don't think there's much walk-in traffic now at all. The walk-in traffic that we see is in the psychiatric crisis service, or the PCS as we call it, the emergency room. That's where people walk in. Short-term hospitalization, that's a key component. As Bruce highlighted, we got diversion dollars from Medicaid many years ago for each diversion that we accomplished that lasted at least a month. So we were able to garner a lot of funding, at least a lot of kickoff funding for the MUTT team. And that became sort of our pattern, what we were known for, managing care. I don't know how it occurs in your communities, but at least for the wraparound children, we had the responsibility, the opportunity to manage inpatient care and keep it at a certain level, and we did. When I was running the team, and I actually don't run the team anymore, I'm actually a consultant for the wraparound program. I talk to care coordinators on a daily basis about their crisis plans. So my role is to do that now. But back then, not too long ago, just a couple of years ago, I did have responsibility for length of stay, inpatient care, gatekeeping, that kind of stuff. So that's absolutely true. And we got it down to about an average of 2 days stay for wraparound child. Now keep in mind, these are children who arrive with the most complex needs in the system, these wraparound children in Milwaukee. Primarily coming through the courts. We've added a voluntary wraparound component in the last few years, but primarily they're coming through the children's court system, delinquency management, child welfare, and these kids have complex needs, deep needs. Prior, back in the 90s, 80s, they would stay at psychiatric hospitals for 3 to 6 months. Remember, who remembers that, right? And now we take these children with these deep needs and we keep them in a psychiatric hospital for 2 days. And when I left the MUTT team, on average, there was probably for 1,100 children in wraparound, an average of 1 day stay per child per year. That's all they got. And we kept them safe, and we helped them to enter and remain within a system of care and get their needs met in a much more creative way. Linkage and follow-up. We don't have, I also work with the state of Nevada, who has a case management, they actually call it that. I know we're trying to move away from that, and I encourage you to. But they have a case management system whereby a crisis team of 2 will go out and see a child and a family, and then a case manager will follow up for 45 days. We had that more formally back in the early days, and now it's informal. So our follow-up is whatever the child needs. We don't assign a case manager. We don't use that term in Milwaukee, but we used to have something that was akin to that. Stabilization services, Bruce alluded to, when the law changed, in 2002, we really took advantage of that. And in Milwaukee, and I'm not sure, Bruce talked about the blended funding, the pooled funding between two primary sources, Medicaid and child welfare for the MUTT team. Medicaid allows for individuals with a high school degree, a relatively clean record. You don't have to have an absolute, just no offenses against children, no serious crimes against people. Relatively clean record, a current driver's license to be trained as crisis stabilizers. And it's the most used service in wraparound Milwaukee. Families use it more than anything else. And I'm here to tell you, there was some discussion about how that is delegated here in New Jersey. I fully support the idea that high school and bachelor's level people can do this work, do it successfully. They do it in a way that's different than professionals like myself. They have credibility with families. They have an understanding of communities that people like myself took a long time to get to. Actually, it kind of hit me in the face and helped me to think differently about kids, but more on that tomorrow. But these folks have a high school degree. They can't have a bachelor's degree. And just to give you sort of a context, I think we used to get $28 per hour for these folks and the work that they did from Medicaid. And agencies would take their costs. And a lot of these folks do this as a full-time job. You could actually have a career as a crisis stabilizer in wraparound Milwaukee. Now, I'm not sure if that's on the, let's see. Yeah, they're here. I'll get to them in a minute a little bit more. But it's again, a very invaluable, I'll say, part of the wraparound Milwaukee system of care. So this is kind of what the state said crisis services are designated or designed to do the following. And they did fall under the direction of the MUTT team. It was my responsibility every 2 years to report back to the state, to keep on top of them for 2 years. Every 2 years, the state wanted to know, how are they doing? Are they writing their notes on time? Are they getting the clinical supervision they need? And that sounds like what you have here. They had a master's level clinician who was required to meet with them 1 hour for every 30 billable contact hours that they had. And so anyway, so more on that in a moment, but here's sort of the array of alternatives. I was talking to Elizabeth, New Jersey, and I was saying that one of my mantras was, you can't take something away from someone without giving them an alternative. So you can't just take away hospitalization, which we did a lot of in Milwaukee, without giving some alternatives to a family. Okay, think about that. If you're going to reduce hospitalization, what else are you going to do? You got to do something. You got to do something like this. And now this is what it kind of breaks down to. Key, and I'm not sure exactly what the state of development is, but we've got peer specialists in Milwaukee who, more for the young adults in the program, in wraparound Milwaukee, in the OYA program and other places, they are tethered to an individual receiving wraparound Milwaukee support, and they have a history of training and their own participation in the system, and they are, again, invaluable. But Families United is also a key component of the whole system of care, and that is families who have had children in the system and are now basically mentoring, advocating for others. I'm expecting that most of you have something like that in your communities. Crisis one-to-one stabilizers, a lot of people want to hear about this. This is what they do. They're very good, but again, there's an array of quality, obviously, so that's why the state required master's level clinicians to supervise them and so on, and they required me to be sort of on top of all of them, which was a job and a half. And again, over 250. These folks primarily get assigned to wraparound children, and they actually develop a one-to-one relationship. They're written into the plan of care. I'll contrast that with the MUTT team, who just sees whoever calls. The MUTT team could see a wraparound child, but they're not going to attach to that child like a crisis stabilizer will. They're supplemental to the MUTT team. And a lot of what they do, which I think is, again, a critical component, is they do preventative crisis intervention. They see the child X number of times a week. Some people look askance at that and say, isn't that mentoring? And I would always say, no, they're practicing. They get the kid in the community. They do supervised contacts in the community, they get feedback to the child, and they practice. So that's, again, something that really helps children to adjust in many ways. Yes?
I asked that question on the slide before. All of the crisis and respite beds, are those all voluntary?
No, a number of them are on a contractual basis, but again, certainly if you're going to use a treatment foster home, you're going to get a day rate for that.
Sure, but is it, in terms of...
They're not mandated by, let's say, child welfare or anything.
It's not commitment status.
No.
They're licensed, but people agree to voluntarily
Yes.
take a child in crisis. Maybe
Although-
the rate will look different, the rate will be higher, so.
We all know some friends in the judicial system who will order children into respite, right? So then it becomes sort of a commitment. Yeah. All right, we're about 5 minutes left. Let's talk a little bit about the composition of the team. This is about how it was when I left it. I really wish I had my little red thing. I love this thing, but it's not working. Did you pull the battery on it? Yeah, I knew it. Milwaukee, Bruce and I didn't really give you context. Milwaukee is an urban setting. And I'm not going to overplay this, but there's a lot of discussion about the violence in Chicago and the risk and all that stuff. Milwaukee is comparable per capita with respect to injury, homicide, that kind of stuff. And the state of Wisconsin was amenable to discussion with me to allow payment for 2 people no matter what in Milwaukee. 2 people could go out on a call because they knew the risk. I'll talk to you more about it tomorrow. I've been involved in more than one situation where there was a gun. Not a weapon, a gun. Okay, so we'll discuss that and how you need the grit and how you need to really sort of try as best you can to wipe the notion of liability away from the hard drive of your brain if you're going to use this, if you're going to do this work. So 2 people, key. And now, as Bruce talked about, there's a team, a trauma team based on the Yale Child Studies model, which I love. More on that tomorrow, but my gosh, they really rely on parents and caregivers as the key to mitigating and to reducing the possibility of PTSD in a child. What a concept. The parent or the caregiver is trained. You don't send the kid to a professional. All right. Anyway. This again, if you look in HFS 34, you'll see all this stuff here. I would require my team, the new folks, even the students, we have a number of students at any given day, to do this in 2 months. I didn't want them to take 6 months to get up to speed. And I had a training orientation checklist that was a combination of shadowing, experienced staff, doing required readings about reporting child abuse, things like that, and emergency rules and all that, and other experiences that led them to be certified. So we were able to certify our own staff and so on. Am I done here? Oh, we'll do this. Okay. This looks a little lower than when I ran it. When Bruce and I say 3,000 calls, that means 3,000 contact calls in the community. Okay, in a community of 1.1 million people in Milwaukee County. 916 initial cases. I'll say initial face-to-face contacts. That's a little lower than it used to be. When I was running it, was about, we would meet 4 new families a day. I'd say that never called us before. We'd start a chart on them and so on and so forth. Is there, okay. Yeah, you're going to do some stuff and then I'll get back to talking about outcomes.
Thanks, Chris.
Okay.
A little bit about funding strategies that we use to support our mobile urgent. Okay, Wisconsin, the way Wisconsin built their Medicaid, where the Medicaid pays for this service under the state plan is Medicaid assumes they cover 60% of the costs for mobile crisis response based on the performing provider's hourly rate. Now, when you get down to the stabilizers who are operating at bachelor's level and at high school level, that 60% becomes more than 60%. That almost is 100%. So a reason to use more of them is that they're actually covering a greater portion of their costs. The way Medicaid figures is 40%, which is the split in Wisconsin of Medicaid, how much has to be matched. That has to be local match, but not kind of it's not a hard match, but you have to show that you have local funds available, and this is for any county. Now, RAP Milwaukee covers the remaining costs of mobile urgent through our pooled funding. And the way our pooled funding, we're under a 1915A agreement, we get a capitated rate for the families we serve. Medicaid pays us $1,892 per member per month for everything. That includes hospitalization. We cover everything. But in addition to that, if you're Medicaid, if you're child welfare youth, one of the 250 child welfare, they pay us $114 a day in addition to the money we're collecting from Medicaid. If they're Justice pays $80 because the costs are different between Justice kids and child welfare kids. They're not the same. They don't look the same. And so we're pooling dollars. We have 400 adjudicated delinquents. So think about it that way. We have, for our 600 kids that are system involved and are in court orders, we're getting child welfare and or juvenile justice dollars. In addition, we're getting the Medicaid dollars. If you're not in the justice system, for the other 600, we're just getting the $1,892 per member per month.
So are you at risk for institutionalization across all those three categories?
You bet. We're at risk for everything other than medical care, but all placements go through us as part of that. And when the court makes a placement, even into a residential center, it's made to wrap around Milwaukee. So it's what we call a flex order. It gives us the ability to move kids in and out of out-of-home care without having to go back to get another court order. We just file a change of placement. So we've done a lot of things. That helps the court. It helps us to keep lengths of stay short, while otherwise you might be waiting for a court, to get a court hearing date. So we get the $750,000 in addition from child welfare, the $90,000 for the trauma team. And then any money saved, because we're at risk, in 5 minutes, because we're at risk, we're able then, if we save dollars, they stay in the system. So we have the ability then, if we're saving hospital dollars, residential, those dollars stay in the system, we're at risk, we pay all the costs of care. So it allows us basically to have a great deal of flexibility, and that's how we pool basically the dollars. So the dollars come through various means, through various formulas, then are pooled. We pay for all the care coordinators, mobile urgent, whatever it is, and then basically all the providers, we pay all of the providers in the system who are in our network. So that's how the system works in the dollars. But we had to design that. I wanted to design that to keep the money. The worst thing you can do is dollars saved leave the system. So there has to be an agreement with the partners. Child welfare and justice don't want to see the money leaving their system. So the negotiation very early on was we keep the money. We keep the money in the system because if you keep it in, you can serve more and more. And you save dollars because it costs a lot less to have kids in the community than in institutions. Your money continues to build up. And for the same amount of money, we might have institutionalized 300 kids in wraparound Milwaukee, now takes care of 1,200 kids. So that's the idea. It can be done. It just takes that kind of extra step in your thinking process. And I know we're
Running out of time.
running out of time. Medicaid can only pay county human service in the state system. That's a little bit about recipients who are eligible for crisis services if they're discharged. These are the rates. You can see that these rates haven't changed for a while.
Crisis stabilization rate is here.
So
And their agencies pay them about $15 to $16 an hour and take a little off the top. So,
and you can see the per diem for group homes. Information technology has been important. We have our own IT system, Synthesis, and basically Mobile Urgent enters their data into the system. So it's our electronic medical record. It's also our payment system. And if they see a child in crisis and they do their notes, the note is also the billing document that then goes to Medicaid. So we know we always have documentation to support a charge that goes, because without that you can't bill the state. So it's all basically set up, and we use a single release of information. Mobile Urgent is on the release. So You have one single child welfare, juvenile justice, the schools, all agreed to have one release, a single page release, allows all the system partners to exchange information. Mobile Urgent is on that. They're automatically on that release of information. So it helps us to talk to one another and move. If you can't talk to one another, it's very difficult to really provide coordinated care. So that is all done, basically. These are just, my final thing I'll just say is the outcomes. I mentioned some of these. Today, the average utilization of kids enrolled in wraparound, which are all kids at risk of residential and hospitalization. Currently, for the 1,216, it's $78 per member per month. So it's 1 day of hospitalization per year for our own
It used to be 3 to 6 months in a psychiatric facility.
So,
and Liz, we got about a 90% success rate seeing children in foster care. We probably see a lot of them, but your 100% in your pilot is great. Keep going, Bruce.
yeah, 50% reduction in
Let me
hospitalization.
talk real briefly. Yeah, there we go. 2.4 days. It was a little bit less a little while ago. Yeah, the success rate for working with children in foster care to keep them there was great. 20 minutes. Milwaukee County is about 10 miles wide, 20 miles long, 241 square miles. So imagine we can get anywhere in 20 minutes. Police love that. So that was their primary outcome.
And I really talked about lessons learned about being the first, and we can finish this in a minute. We've really talked about all of these things. It has been, I wanted to mention, more advantageous to coordinate and link mobile response with child welfare and justice than with the adult system. And I sometimes you have to do that because of your size. But our problem with the adult system, and I heard it was somebody said it earlier from one of the states, philosophically, they're different. Organizationally, they don't like to see adults in the community who they don't know. So it reduces, we don't operate the same way as the adult mobile team. And we've never really been able to philosophically really bring that together. So it's made more sense to really have separate teams and to link our teams more closely with the child welfare and juvenile justice system, make them the fundamental. And we did talk about agreements, the need for crisis services. So with that, we're done.
Questions?
Okay.
So you talk about the differences between adults and kids. Can you talk about that transitional age where they're adults but not really?
Wraparound has expanded to cover up to 21 years of age in what's called Oh Yeah, the Oh Yeah program. And that's voluntary, and so it's sort of a bridge to the next stage. And
So we have transitional services. They can be seen by the mobile team up to age 21.
Yep.
Sometimes they get in the adult system. There's where we're using our peer supports, our young adult peer supports to work with other young adults. So, but it's young emerging adult here. Why it's named Oh Yeah is I always change them when we applied for federal grants. We got an HDI grant. I used the same grant writer. I always changed his names because I thought they were really, and I said, this time I'm going to leave it. I'm going to leave it alone, and we got the grant. So
The follow-up, because, under the current ACA, child welfare goes up to age 26. So how do you treat those youth that may come to you? They're past 21, but they're still connected to child welfare.
There are a number of programs available to young adults, targeted case management. There's now CCS, comprehensive community services. So there are other things that are not wraparound proper, but within our broader system of care in Milwaukee County are available.
we can go to age 24 now under
Yeah.
our contract for HTI. We can't go to 26. We can go to 24. And that's an expanding program now, is our Healthy Transitions population. That's expanding really, really rapidly in Milwaukee. So we're beginning to see many more of those kids. Medicaid will fund it if they are kids that transitioned at some point out of a foster home. We can cover them, but we can't cover all young adults if they don't meet that qualification. But there are other programs, as Chris is saying, that is designed to cover them. So we're getting better. It's an important age.
Okay.
Important.
Thank you.